So a very good evening to all those faculties and residents who have joined for this National Clinical Meet series for the month of March, being hosted by AFPI Kerala chapter. We are having interesting discussions throughout the year. And today we have again come up with a very important topic relevant to our clinical practice as well as as far as the residents are concerned for their exams. The topic is evaluation of or approach to a breast lump. And the speaker for the day is Dr. Soumya K. Sakriya and Dr. Ali Madam. She's the family consultant, family physician at FHC Matatur, and the second chairperson for the day is Dr. Jitu TG. He's a consultant in general surgery from KIMS Hospital, Trivandrum. Both are excellent academicians and practitioners. And I would hand over to the chairpersons to proceed with the meeting. Over to Ali Madam.
Thank you, Vishnu. I would like to give you a warm good evening to all who has entered the clinical classroom. I want to introduce Dr. Soumya K. Sakriya, who is the presenter for the day. She is a consultant family medicine in Muthoot Healthcare, Porangeri. She finished her MBBS from Calicut Medical College in 2009. She finished doing her DNB family medicine from Christian Fellowship Hospital, Odanjitram, in 2017. So this topic is very relevant to all of us, even today. Me being one of her seniors who finished 20 years back from Odanjitram, and we enjoy the company of Soumya while presenting it, and we'll enjoy the clinical feast. Over to you, Soumya.
Thank you, Ali ma'am. Thank you, Vishnu. I'll share my screen.
See, before starting the meeting, I would request all the non-participants to mute your mics so that the session goes uninterrupted. It's very important as far as the session is concerned.
Shall we start?
Yes, Soumya.
Okay.
Respected chairperson, Vishnu. Dr. Jitu is present, no?
Yeah, Dr. Jitu is here.
Okay,
Dr. Jitu, can you?
Good evening, ma'am. Dr. Jitu here. Yeah, I'm a consultant surgeon at KIMS Hospital, Trivandrum, and it is very heartwarming that I am here with you guys. So let's hope that it's going to be a good academic session.
Thank you, Jitu. Soumya, you can start.
Respected chairpersons, senior consultants, and dear friends, very good evening to one and all. So today, first of all, I thank AFPI National team as well as the Kerala chapter for this wonderful opportunity. So today we will be discussing about how to approach a breast lump, as Dr. Ali Madam has already given the introduction. So is my screen moving?
It's not moving.
Can you just stop sharing and share once more?
Yeah, it has started moving. It has started moving, Soumya. You can.
So today, regarding the topic, so we will be discussing this topic under the following headings. That is, first I'll be going through introduction, then a differential diagnosis about the breast lumps, then about the triple assessment, that is the evaluation part, then about some common benign breast diseases, then carcinoma breast, then about a few slides about the breast cancer screening and the importance of it, and the hereditary breast cancer. Talking about, so why are we discussing about this topic? So we know that like in our OPDs also, we see many women who like come to us with complaints of breast diseases. Maybe they'll be coming about various complaints, but many women come to us like with various complaints. So studies tells that 30% of women suffer from any breast disease in their lifetime. So they may be coming to you with complaints of pain. It's not breast cancer, but any breast disease that they are talking about here. So they may be coming to you with complaints of breast pain, feeling of lumpiness in the breast, or telling like they have a breast lump. So how do we evaluate such patients that are coming to us? So in the evaluation, our aim is like to exclude cancer. Why to exclude cancer? I will be talking to you about in the next slide. So first exclude cancer and then treat any other remaining symptoms that is present. So why exclude cancer? This is a slide which shows the burden of breast cancer. So this data is taken from the Globocan 2022 data study by the International Agency for Research on Cancer by WHO. So this shows the incidence of cancer among females in India. So this tells us that almost 1 in 4 cancers being diagnosed among women in India is a breast cancer. That is, if 4 cancers are being diagnosed, 1 is a breast cancer. The incidence of breast cancer in 2022 among females in India is 1,92,020. That is like shown in the pink color here. So this slide also tells us why we need to detect breast cancer in the early stages also, because of the heavy burden of the breast cancer. And about the breast cancer screening, I will be dealing in the subsequent slides. So about the breast lumps are a common presenting complaint among women. But if the patient is like coming to you with complaints of breast lump, we need not always think that it is a benign, it's a malignant disease. Predominantly, most of the symptoms, about 80 to 90% of the breast lumps that we see across are always benign. But because of the cancer burden, malignancy needs to be ruled out in all the cases. Coming to the differential diagnosis. So what are the causes of massive enlargement of breast? So the common causes includes benign hypertrophy, which is usually bilateral, which could be bilateral, then giant fibroadenoma, serocystic disease of Brody or the Fulot's tumor, sarcoma, colloid carcinoma, filariasis of breast. Coming to differential diagnosis of cystic swellings in the breast, it could be bloodgood cyst, breast abscess, hydatid cyst, galactosele, serocystic disease of the Brody, cystic necrosis in carcinoma breast, lymph cyst, or a hematoma in breast. Coming to differential diagnosis of carcinoma breast or heart lumps, it includes fibroadenosis, traumatic fat necrosis, tuberculosis of breast, bloodgood cyst, filariasis of breast, mastitis, antibioma, galactosele, Mondo's disease, or cystosarcoma phyllodes. So when a patient comes to you with complaints of breast lump, how do you approach such a patient? So the approach is termed as triple assessment. So the triple assessment will have 3 parts or 3 phases. The first phase is the clinical phase, which includes history and examination. The second phase of the triple assessment is the imaging, which could be either ultrasound or mammogram, about which I'll be dealing in the next slides. And the third phase is the pathology, histopathology, which could be either fine needle aspiration cytology, that is FNAC, or a core biopsy, or could be both also, depending on the condition of the case. So these 3 phases together helps us in a confident diagnosis in more than 99% of cases. So it's clinical assessment, imaging, as well as pathology. This together can help us in a confident diagnosis in 99% of cases. So coming to the first phase of the triple assessment, that is clinical, it includes history as well as clinical examination. So in the history, just rushing through that, since these are all very basics. So it includes first is age and social status. So we all know that incidence of breast cancer increases with age. So if a patient who comes to you with a breast lump is like 45 or 50 years of age, we will be suspecting more of breast cancer than a benign disease. And if it is less than 35, or if a 20-year-old girl coming to you with complaints of breast lump, you'll be thinking more of fibroadenoma. So the incidence of breast cancer increases with age, whereas fibroadenoma usually occurs less than 35 years of age. And also we see that in developed countries or in an urban setup, carcinoma and fibroadenosis are more common compared to the rural or underdeveloped countries. Coming to the next thing and history, that is the history of presenting complaints and associated factors. So when a patient comes to you with complaints of breast lump, we should ask for the mode of onset, if it is a slow growth or a fast growth. Then also the associated factors like pain, nipple discharge. So if the patient has a pain, which is a cyclical pain, it will be more indicating towards fibroadenosis. And if the patient has a nipple discharge, which is bloody in color, so we will have to think about if it is a duct papilloma or malignancy. And if the patient complains about pus discharge, pus in the nipple discharge, we can think about abscesses. Or if it is the nipple discharge is milky in color, we can think about galactosele. Or if it is a green or serous, we should be thinking about ductatasia or fibroadenosis. So these are all pointing towards the final diagnosis among the history part. So as equal as the other history part is the menstrual, marital, and family history in a breast cancer. So we all know that nulliparous, unmarried women are more at risk for malignancy. Also, early menarche is also indicator of is also at risk for malignancy. And if there is a family history of breast cancer, that is also indicating towards high risk of malignancy. So these are regarding the just a framework regarding the history part. So in this slide, it shows in the age category, it shows the common causes. So we see that most common cause in all these will be benign diseases, and more than 25 years, we will be thinking about breast cancer. And the red flag signs are important. So when a patient, a very young girl comes to you with complaints, we should be thinking, we should be looking at the red flags, right? If it is a irregular firm mass, if there is any skin erythema or tethering of skin is there, if there is any history of spontaneous bloody nipple discharge, if there is any new onset nipple retraction, if it is from the beginning, it's okay, but if it is a new onset nipple retraction, it's a red flag. And if it is a rapidly enlarging mass. So these are the red flags among the breast lumps. So coming to the clinical examination part, first is the inspection. So during inspection, the most important thing is the exposure. So the patient should be exposed up to the waist. Both sides of the breast should be raised. It should not be like one side only exposed. Both breasts should be exposed simultaneously, because basically here we'll be comparing between both the breasts. So we examine in different positions, like with arms by side of the body, with arms raised above head, like in the second picture, or like hands on the hip, and also in the bending forward position. So as I told, in the inspection, we will be comparing between both the breasts. So looking at the breast, we should be looking at the position of both the breasts, looking at the size and shape of the breast. If one breast size is different, other is small or big, that should be looked into. Then any puckering or dimpling visible in the breast. And if any visible swelling is like noted in the inspection, we should note down the size, position, which position the lump is present, like according to the quadrants, then shape and surface of the swelling. Then after the breast, don't forget to look over the skin over the breast. Color and texture of the skin over the breast is important. If there is any presence of any engorged veins, that could indicate a Pilot's tumor. And dimpling, retractions or puckering, pudiorange appearance, nodules, ulcerations, and fungations will be seen mostly with the malignancy. Next, coming to the nipple, we should look into the size of the nipple, position of the nipple, if it is like pulled upward or downward like that, then number of nipple, usually would be a congenital thing, then surface of the nipple and any nipple discharge that is like coming out. And also look into the areola, arm and thorax, axilla and supraclavicular fossa, and also the inframammary area. Look for any visible mass in these areas. Next step in the in clinical examination is the palpation. So here, while palpating, the position is usually sitting, semi-recumbent or recumbent positions. So not that you palpate the normal breast first and then go to the diseased breast. So how should we palpate? We should use the palmar surface of the middle 3 fingers as shown in the picture. And all the 4 quadrants should be assessed separately. We should palpate tissue in superficial, intermediate, and deep tissue planes if the patient has a huge breast, as a large breast. So when you look for palpation, like in the picture, the patient is lying down, keep the hand of that side, which is like being examined, keep that hand above the head of the patient. So look for any local temperature and tenderness. If any local tenderness or temperature is there, it could indicate a mastitis or any abscess. And situation of the lump, where the lump is like, in which position is like the lump is present. If it is a multiple lump or a single lump. So if it is a multiple lump, it could be mostly a benign disease, whereas if it is a single lump, it could be anything, but malignancy is also a factor. And size and shape of the swelling, the margin of the swelling, if it is a regular margin or if it is an irregular margin. So regular margins will be indicating about benign disease, whereas if it is a regular margin, it is a benign disease. If it is irregular margin, it could indicate malignancy. Also, look at the consistency of the lump. If it is a hard lump, it could indicate malignancy. If it is a cystic or hard lump, we should differentiate with palpation. Also, look into the fixity to nearby structures like skin, breast tissue, fascia, or the chest wall. The fixity to the underlying tissues indicates malignancy. And also examine the axillary and cervical lymph nodes. So never miss out during the clinical examination to check for. These are the things that we can miss out during our busy OPD practice. So to check nipples for discharge or distortions, look into the axilla for any mass, lymph nodes. Look into the supraclavicular area for supraclavicular lymph nodes. Look into the chest wall for any infiltrations or fixity. Look into the cervical lymph nodes. So this is the picture showing how examining the axillary lymph nodes. So next in the triple assessment, the second phase or the second part of the triple assessment is the imaging. So here, the most commonly what we do is mammogram or ultrasonogram. So if mammogram versus ultrasonogram decision is taken by the age of the patient and also the breast density. So the first picture is showing the mammogram picture of carcinoma breast. The second picture, C and D, indicates shows ultrasound images of carcinoma breast, whereas the E image shows the MRI breast image of carcinoma. So coming to the mammogram, so we usually do mammogram for age more than 40 years of age, and also if it is a low dense breast tissue, the sensitivity of mammogram will be more compared to ultrasonogram. So in the mammogram, we are using a low voltage, high amperage X-rays with a radiation of 0.1 centigrade. In this image, we see the compression plates, the X-ray source, and the X-ray beam is like coming like this from the up down. So mostly in the mammogram, we are using 2 views. One is a craniocaudal view, that is a CC view, and the mediolateral oblique view. So we will be looking at both the views in the mammogram. So the pointers towards malignancy in a mammogram is microcalcifications, irregular margins, spiculations, duct distortions are indicators towards malignancy. Mammogram will be reported mainly as a BIRAT score, that is the breast imaging reporting and data system score. So it varies from a score from 0 towards 6. So if the BIRAT's report is given as BIRAT score 0, it means it's an incomplete study. So that patient will require additional evaluation. If the report comes as like BIRAT's negative, that is BIRAT's 1, it means it is negative. That is the patient does not have any swelling. So for such people, we can continue like annual screening routine. If it comes as BIRAT's 2, then it means a benign lesion is present there. Could be fibroadenoma or fibrocystic disease. So in such patients also, there is no risk for malignancy. So we can continue routine annual screening. But the management, if it is a fibroadenoma, the patient wants to go in for excision, they can go in for leg. But regarding the carcinoma part, they can continue routine annual screening. We see that in BIRATs 1 and 2, the likelihood of cancer, breast malignancy is essentially 0. In the BIRATs 3, it is like probably benign. That means it could be probably benign, but not 100% surety. So such patients will need a short interval follow-up, especially in 6 months. Their routine 6 months follow-up. So for such patients, if it is a BIRATs 3, the likelihood of cancer, we see that it is less than 2%. If the BIRAT score comes as like score 4, that means it's suspicious for malignancy. So in such cases, biopsy is indicated. If it is BIRATs 4A, if there is low suspicion for malignancy, that is, it's 2 to 9% chance of becoming malignancy. If it is 4B, then 10 to 49%. If it is 4C, we see that it is 50 to 94%. If it is BIRATs 5, we see that it's highly suggestive of malignancy, whereas biopsy is required. So we see that likelihood of cancer in BIRATs 5 is more than 95%. More than 95% of BIRATs 5 lesions could be malignancy. BIRATs 6 is a score given for non-biopsy proven malignancy. If it is a confirmed breast cancer, when we do a mammogram, they report it as BIRATs 6. So the take-home message from this slide is, if it is a BIRATs 3, we should follow up the patient in 6 months. If it is BIRATs 4 and 5, needs to be biopsy. Tissue diagnosis is mandatory. And if it is BIRATs 1 and 2, we can reassure the patient. Coming to the next modality in imaging, that is the ultrasonography. So we do mammogram for women more than 40 years of age. So for women less than 40 years of age, we will be recommending ultrasonogram, because usually the young women breast is like is a dense breast. So ultrasonogram have more sensitivity than the mammogram. The ultrasonogram, it helps us in distinguishing between solid and cystic lesion. This ultrasound image shows image of a fibroadenoma with regular margins. So it also helps us in distinguishing between cyst and solid lesions. So it's also useful in guided biopsies. If this size of lump is like really small, it also helps us in guided biopsies. So that is the indication of ultrasonogram in breast cancer, breast imaging. Just a slide about MRI breast. It's not routinely done. MRI breast is usually done only for very high-risk population, like in very significant family history. It can be useful to distinguish scar from recurrence in women who have had previous breast conservation therapy for cancer. And also women who has like breast implants, MRI breast is the imaging modality of choice. Coming to the third component of the triple assessment, that is the histopathology. So first we talked about the clinical part, then the imaging part, and then coming to the histopathology. So in the histopathology, I told you it's FNAC or the core biopsy. So first talking about FNAC, this image shows the ultrasound guided FNA picture. So usually FNAC is done if there is low probability of malignancy. That is, if a young, maybe a 20-year-old lady comes to you and you find that it is a cystic mass, she doesn't have any significant risk factors, there is no family history or such things, then we can suggest FNAC for such a patient if it is a young cystic mass and with no significant risk factors. So cytology is usually obtained by using a 21 gauge needle or 23 gauge needle and 10 ml syringe with multiple passes through the lump. We identify the lump, and through the lump, with or without the ultrasound guidance, we can do the multiple aspirates and fix it in a slide and do the cytology. So it is a least invasive for cell diagnosis. The disadvantage of FNAC is that it cannot differentiate in situ and invasive cancer disease. So here comes the role of the core biopsy. So, so when you do the aspirate, when you do the fluid aspirate, you see that it is a non-bloody, and the cyst also disappears. This lump disappears. So that indicates it's a benign cyst. The thing you can do is like you can repeat the clinical examination after 4 to 8 weeks and to look for any recurrence. If you see that the fluid aspirate, it is non-bloody, that does not contain blood, but it does not fully disappear. For such cases, you can do re-imaging and see what is left behind. If you see that it is a bloody discharge, we have to look into the cytology report for any presence of any malignant cells and consider re-imaging. Coming to the core biopsy, I also already told you, core biopsy helps us in differentiating between the ductal carcinoma in situ and invasive disease. So if you find a lump here, if you find a lump inside here, you can like direct the needle towards the lump. You have to fix the lump first, then direct the needle towards the lump and take a tissue biopsy straight with the through-cut biopsy made. So it's preferred for solid and suspicious masses. If you are like thinking more towards malignancy, then the best histopathology can be done is the core biopsy. The advantage of doing core biopsy in the suspected malignancy is like, if it is an early breast cancer, it helps us. If it is a suspected breast cancer, if we can do hormone receptor status also in the same sample, which helps us in the neoadjuvant therapy, mainly for locally advanced cancers. So summary of the evaluation of the breast lump. So if you see the breast lump, it is cystic, or see that if it is cystic or solid. And if it is cystic, you do a lump aspiration, the lump disappears, or the aspirate fluid is like clear fluid, we can mainly discharge the patient. If the cystic swelling, once aspirated, has a residual thickening, or if it is a blood-stained fluid, they might go for further evaluation, might need a core biopsy. And if it is a solid lump, and ensure that after histopathology, you find that it is a benign lump, we can offer excision in such patients. And if it is atypical, we'll have to go for core biopsy. If it is a malignant, confirmed malignancy, then we'll go in for the cancer pathway. So coming to the common benign breast diseases, I would like to start with ANDI, that is the aberrations in normal development and involution. We see that the most or almost all common benign breast diseases comes under the ANDI. So why ANDI? We know that our female breast, women breast, they undergo dynamic changes throughout their reproductive life, and also through each menstrual cycle, it undergoes very dynamic changes. So if any disturbance that happens during this normal breast physiology results in aberration in the normal development and involution. This is the pathogenesis of ANDI. So coming to the stages of ANDI, it can happen in like 3 stages, maybe in early reproductive years, like in 15 to 25 years, or in a mature reproductive age group, like 25 to 40 years, and involution happens in 35 to 55 years. So these are the normal process that happens in a woman's life cycle, in their reproductive life cycle, in the breast development and involution happens. So if any aberration happens in any of these stages, if any aberration happens, it can result in a disease. It could be just an aberration, or it can end up in a disease. So like if any aberration happens in the lobular development, aberration developed is fibroadenoma. So it can lead to a disease like giant fibroadenoma. So like if any aberration happens in the nipple eversion, it can lead to nipple inversion. It can result in subareolar abscess also. So any aberration happening in the lobular involution can result in the macrocyst that is like commonly seen in the 35 to 55 years of age. So that is ANDI. So talking about fibroadenoma, which is one of the most commonly heard breast disease. So we see that it is most common in the age group of 15 to 25 years of age, that is in the younger age group. As I already told you, it arises from hyperplasia of a single lobule and can grow up to 2 to 3 centimeter in size. A giant fibroadenoma is usually more than 5 centimeter in size. So fibroadenoma, it is characterized by well-defined capsulated margins. It will not be irregular margins, it will be well-defined margins, and it will be capsulated. So when is the excision indicated for fibroadenoma? If it is a suspicious cytology, then definitely the patient have to undergo excision. And if it is a giant fibroadenoma, that is more than 5 centimeter of size, and patient is like concerned, we can go for a excision. And third is patient preference. If the patient wants to go for excision due to cosmetic reasons or their personal needs, they can go for excision of the fibroadenoma. Next is the breast disease, breast cyst. So as I told in the ANDI slide, it occurs in the last decade, that is during the involution phase of the reproductive life. So it happens due to non-integrated involution of, that is aberration in the involution of stroma and epithelium. So it can happen like as a single lump, or it can be a multiple lump. Maybe it can happen in unilateral, like in one breast alone, and also can be bilateral in both the breast. As it occurs in the last decade of reproductive life, people will be really in panic thinking that it is malignancy, and it can mimic malignancy. So diagnosis can be, since this is a cystic swelling, so diagnosis can be confirmed by aspiration and ultrasound. Since it happens in this age group, it can cause a great alarm to the patient and the bystanders. So when we give a prompt diagnosis and when the drainage provides symptom relief, it gives a big relief to the patient also. Coming to the phyllodes tumor, it's also known as serocystic disease of Brody or cystosarcoma phyllodes. It usually occurs in women more than 40 years of age. They're present as a large, sometimes massive tumor with an unevenly bosselated surface. This image shows a huge phyllodes tumor. So we see that it is a massive tumor with uneven surface and also bosselations at some part. And also ulcerations can occur in the overlying skin due to pressure necrosis, as you see in the image. Thing is, despite their size, they remain mobile on the chest wall. This slide is taken from the Bailey. So it shows the risk of malignancy in the benign breast diseases. So we see that there is no increased risk of a benign breast disease becoming malignancy in these cases, like adenosis, breast cyst, fibroadenoma, ductectasia, fibrosis. All these cases poses no increased risk towards malignancy. And there is a slightly increased risk, that is like about 1.5 to 2 times increased risk is seen in cases with hyperplasia, moderate or florid, slow, solid or papillary, papilloma with a fibrovascular core. And there is a moderately increased risk, that is like 5 times increased risk, which is seen in with biopsy report like atypical hyperplasia, could be ductal or lobular, which moderately increased risk is seen. So this is about the common benign breast diseases. So a few slides about the carcinoma breast, just an overview. So carcinoma breast is mainly, could be early breast cancer, or it could be a locally advanced breast cancer, or it's a metastatic breast cancer. We say it is an early breast cancer, usually in T1 and T2 lesions with N0 or N1. It is a locally advanced breast cancer if it is a more than T3 lesion, or more than N2 is in, more than N2 lymph nodes are involved. And if it is a distant metastasis is there, it's a metastatic breast cancer. So it's early breast cancer, locally advanced breast cancer, or metastatic breast cancer. So coming to the management of breast cancer, it's usually a combination of any of this therapy or all the therapies, depending on the stage of the disease. So surgical modality of treatment is there, radiation therapy is there, and systemic therapy is there. The common surgical procedures involved in breast cancer surgery is breast conservation surgery, mainly used in the early breast cancers, and nowadays recommended by the surgeons and also preferred by the patients. Modified radical mastectomy, then axillary dissection versus sentinel lymph node biopsy, depending on the lymph nodal status of the patient. And radiation therapy, then systemic therapy includes chemotherapy, hormone therapy, targeted therapy, immunotherapy. In many of the cases, most of the cases, I would say it is a combination of any of these therapies, multiple therapies for the treatment of the patient. A patient might require different modalities of treatment. Just one slide about the breast conservation therapy. So I told you it's done only for early breast cancers. It's not indicated for advanced breast cancers. So in early breast cancers, the surgeon will be taking out, doing a wide local excision of the breast tissue along with the lump. Also, radiotherapy will be given to such patients. So that's why it's breast conservation therapy. It's breast conservation surgery plus radiotherapy. So if it is a clinically lymph node negative patient, if the lymph nodes are not palpable clinically, they will be also doing a sentinel lymph node biopsy. And if the lymph nodes are clinically palpable, they will be going for axillary dissection in such patients. So we know that the sentinel lymph node biopsy is like the injected dye, and when the dye goes to the first lymph node, the draining lymph node, they identify it with the probe, and that lymph node will be taken out for the biopsy. The systemic therapy, it could be a neoadjuvant therapy or an adjuvant therapy. So if it is the systemic therapy is given before surgery, that is a neoadjuvant therapy that is most commonly used for the locally advanced breast cancers. So it's a neoadjuvant therapy. That is the systemic therapy given before surgery. First chemotherapy is given and then surgery is done. And if it is an adjuvant therapy, it is given after surgery. That is the chemotherapy done after surgery is the adjuvant therapy. Multiple regimens are available. Most commonly used are the anthracyclines and taxanes. So I told you regarding when the histopathology slide about the hormone receptors. So the hormone receptors that is normally looked for in breast cancers are the estrogen receptor, progesterone receptors, HER2 receptors, and Ki-67 receptors. So depending on the positivity of these hormone receptors, mainly the ER, PR, and HER2, the breast cancers are differentiated into molecular subtypes. It is as luminal A, luminal B, HER2 positive or triple negative breast cancer. Coming to the hormone therapy, if hormone receptor, that is ER/PR status is like positive, patient will receive hormonal therapy up to 10 years post chemotherapy. And if it is a HER2 positive patient will receive HER2-directed cell therapy called trastuzumab for 1 year along with chemotherapy. This slide is very important for all the family physicians. We will be like more dealing with the cancer prevention. This slide shows us that if it is a localized disease, that is an early breast cancer, the 5-year survival rate of those patients is 99%. That is, if a breast cancer is detected in like stage 1, that is a localized disease, that there is a chance that the patient will live more than 5 years, is like 99%. That percentage comes down to 86% if it is a regional disease, and drops down to 31% from 99 to 31 if it is a metastatic disease. So this slide shows us why breast cancer screening and why early detection of breast cancer is very important, because it changes the scenario from a 99% of 5-year survival towards 31% of 5-year survival. So with this slide, I would like to talk about the breast cancer screening. There are multiple guidelines for breast cancer screening. This is the NCCN guidelines. For an average risk population, if the age of the patient is like more than 25 but less than 40 years, NCCN guidelines tells about screening as clinical encounter, that is clinical breast examination every 1 to 3 years, and breast awareness. It's same as the self-breast examination. So each woman, they should be aware about how their breast feels. That is the breast awareness. So that is the guidelines for the age 25 to 40. And if age is more than 40 years, NCCN guidelines tell annual clinical encounter, that is clinical breast examination by a healthcare practitioner every year, then annual screening mammogram every year, and self-breast examination, which should be done like every month. These are the multiple breast cancer screening recommendations by different organizations. The most commonly used one are the ACOG, NCCN, and the US Preventive Service Task Force. So most of them tell about regarding the mammogram, more than 40 years, yearly mammogram. USPSTF tell about the biennially in persons 50 to 74 years. Clinical breast examination is recommended annually or 1 to 3 years in 20 to 39 years, but annually for everybody more than 40 years. And about the self-breast awareness, it is recommended by most of the studies, most of the organizations. Regarding the clinical breast examination part, I've already discussed. There's one slide to emphasize the importance regarding the screening. The study from TMH Mumbai, that tells that if CB, the clinical breast examination, is implemented as a breast cancer screening method in India, it would save 15,000 deaths from breast cancer each year and 40,000 lives globally in low and middle income countries. So at least in low middle, at least if they do clinical breast examination, this is the end result from that. So coming to breast self-examination or the breast awareness, as I told you, the recommendation is that each female should be aware about how her breast is felt. So self-breast examination is recommended during the 7 to 10 days of the menstrual cycle for a menstruating woman, or a postmenopausal or post-hysterectomy. They can fix a date in a month, and they can do monthly self-breast examination. So the steps recommended by WHO is in the step 1, proper exposure is like indicated. That is, both the breasts should be examined simultaneously. So in the step 1, stand in front of a mirror, compare between both the breasts, look for any color, shape, or size difference of the breast in front of a mirror. And in the step 2, they should raise their hand above the head and check for any difference between either breast. In the step 3, they will be lying down, and the side of the breast which is likely being examined, that hand should be behind the head of the person. And with the other hand, with the palmar aspect of middle 3 fingers, they can check for any lumps or bumps using the fingers. And in the step 4, in the same lying down position, they can check for any secretions coming from the nipple. And in step 5, they can, while taking a shower, they can raise their hand above the head, the side being examined. And with the other hand, they can feel for any lump or discharge and look for any nipple discharge. Just one last slide about hereditary breast cancer, because this is a question being questioned that we will be facing from many of the patients that come to us. So when they have a family history of breast cancer, usually patient comes to us with these questions. This slide tells us, like, out of all the breast cancers that are being diagnosed, only 10 to 15% of the breast cancers have non-mutations. And out of this 10 to 15% of breast cancer presenting with mutations, 30% will be like BRCA1 positive and 30% will be BRCA2 positive. The significance of BRCA1 positivity and BRCA2 positivity is like, if they are like BRCA1, BRCA2 positive, then we have to evaluate the first degree relatives. And if they are like BRCA1 and BRCA2 positive, if the first degree relative is BRCA1 positive, it tells that they have a 50 to 65% chance of developing breast cancer. And BRCA2, it is 40 to 55%. And for a BRCA1 positive patient, they have an increased risk of ovarian cancer by 40 to 65%. Whereas if it is BRCA2, the increased risk of developing ovarian cancer is only 15 to 25%. So this is the significance of BRCA1 and BRCA2. So I would like to conclude here. My take-home message would be, all the breast lumps needs to be evaluated, and the first aim of evaluation is to rule out malignancy because of the high incidence of malignancy. And whoever comes to you, maybe they will be coming for diabetes, or maybe for hypertension, or maybe like any other complaints, encourage clinical breast examination in all women and teach them about the self-breast awareness. And keep in your mind that majority of the breast lumps are benign. And if the breast cancers are detected in a very early stage, like in early breast cancer, there is a 19% of 5-year survival in such patients, and 99%. So early detection can save life. Thank you. Thank you.
Thank you, Soumya. That was a very clear and crisp presentation. I hope it would have been useful for almost throughout. There was around 100 participants for your class. So that was a lot of takers. As a family physician, I would actually want you to sum up again, which should not be missed in their practice. That is, as you have triple examination and screening, all that you have been saying. Just highlight just the points when a family physician see a lady with breast lump. Just highlight once more.
So the first and foremost important thing is like ask for a good history. A thorough history examination is a must in all the patients. So after the physical examination, after history taking, go into the physical examination. Look for have a good clinical examination. Properly expose the patient. Most patients will be like they will not be like very happy to expose themselves in front of, even if you are a female. So make sure that you expose the patient properly and do a good inspection and palpation and see if it is a cystic mass or if it is a heart mass. And after the clinical examination, first think in your mind if it is a benign or it is a malignant. Then after the clinical examination, decide whether to do the imaging. Most of the cases, if it is more than 25 years, better to go for an imaging. So if you find, according to if it is a less than 40 years, you can go for ultrasonogram. Or if it is a more than 40 years, mammogram is the indication. Or if you feel mammogram is the choice of investigation in more than 40 years of age. So after according to the findings in the radiological finding, along with your correlation with your clinical examination, you can decide upon the histopathology. So all these three components are like equally important in reaching into your final diagnosis.
Very good. How about screening the family members if they are turned positive for cancer? So that we will need to address. That is a major question they come up with. How will we go about it?
So my answer to this question would be like each and every woman in whoever comes to you will need a breast cancer screening, irrespective of the family status. If family history is there, then they are like at increased risk. But we saw like out of 4 cancers happening in to Indian women, 1 is a breast cancer. So we can't like tell that you don't need a breast cancer screening. So each and every woman coming to you, or each and every woman that you come across, maybe for any different thing, should undergo a breast cancer screening would be my answer to that.
Yeah, correct. Basically, if they have first degree relatives already positive for breast cancer, they have a twofold risk. And if they have very closer relatives, two relatives having breast cancer, they have a threefold risk. So this should be emphasized by the family physician. That is very important. And all of us, we should very systematically examine is the first question. And then it is our privacy in a busy schedule, all that matters. But still we should, once it is a breast lump, never, as you said, expose the patient and then ask for history, as well as a good clinical examination makes their prognosis much better. There are a lot of controversies regarding, self-examination makes a lot of diagnosis per se or biopsies increase, and it is not relevant at all. But as far as one of your slides showed, in India, it's a very relevant screening tool, according to me. Because as far as for the past 20 years in my clinical practice, I still feel many of our Indian women are, they are very reluctant to show or reluctant to be examined if it is a breast lump. So that still happens in our community. So it is a very good tool to bring out early diagnosis of breast cancer.
Ma'am, Dr. Jitu,
If you can add on, yeah.
Once again, congrats to Dr. Swami for presenting such a beautiful class. Actually, it was very informative for, I guess, all of us. I want to add some few points regarding this. As a doctor, when somebody comes to you, a female comes to you with a breast lump, every time in their mind, they have always a concern for being diagnosed with a cancer. So the approach towards that patient, like how much they are aware of a disease, what is their thinking about a breast disease, all that is very much important prior to telling a diagnosis in front of them. You have to be very empathetic about the patient's mental scenario also. So many of the time for us, it is just a breast lump, but for a patient, it is a matter of their life and all these things. So that is one thing. Second thing, which we commonly come across practice is a condition called as granulomatous mastitis of the breast. So many often this condition also present as a lump, especially painful lump, being patient would give in history of an abscess being drained multiple number of times, still presenting as discharging sinuses, non-healing ulcer, all this condition they will tell. So when we do an ultrasound, most probably we will get an ill-defined inflamed lesions. So in that case, again, biopsy is mandatory. And in that case, we usually go for a wide excision, maximum excision of the necrotic tissue. And you might require an adjuvant treatment with steroids and all. So that is one of the condition. And another which sometimes disturbs us is a infected galactosele. So especially the postnatal mother, when she comes with an infected galactosele, there is always there is a pain factor. And second problem for her is that inability to feed her child. So how to manage a breast galactosele, infected galactosele? So ideally, in any infected breast, if a breast abscess or anything is there, we go for a IND. But if we go for an incision and drainage in a case of an infected galactosele, it might precipitate a formation of milk fistula. So that will be very difficult to deal with. That is, cosmetically very difficult to deal with. And for her, for the rest of the breastfeeding part also, it will be very difficult to deal with. So usually in an infected galactosele, we usually manage it with a sequential aspiration with the appropriate antibiotics as per the culture sensitivity report. And even after 3 or 4 aspiration, it doesn't settle, and it is full-fledging into an abscess formation. Systemic signs of sepsis is present and all. We might have to deal it with surgically. There, you might have to go for a stopping of the breast milk. So you might have to go for medical termination of breast milk expression and all these things. So that is one thing. Another thing which I would like to highlight is regarding Paget's disease versus eczema of the breast nipple. So many of the time, patient presents with a nipple lesions. So they are not sure whether it is a dermatological condition or there is any associated significant malignant issues and all. So in that case, especially for the postgraduate part of students, I would like to, there are certain factors which contribute towards whether it is a Paget's disease bar an eczematous condition. So Paget's disease is usually unilateral, and it is most commonly in perimenopausal or postmenopausal females. And usually there is a nipple destruction is there. And there is, classical features of eczema like scaling and itching may be absent in case of a Paget's disease. And there could be an underlying lump in Paget's disease. So Paget's disease versus eczema is another important factor in which you have to take care. And another thing is reading a mammogram report or ultrasound mammogram report. There are certain things which point us that this patient requires, careful evaluation. One is the word of echogenicity. Hypoechoic lesions are always dangerous lesions. Iso, hyper, anechoic lesions are lesions which can be actually followed up. But hypoechoic lesions, usually atypical fibroadenoma onwards, there is a hypoechoic lesion starts coming on. So hypoechoic lesions with posterior acoustic shadow, presence of axillary adenopathy, or like irregular margins, then presence of microlobulations, angular margins, presence of microcalcifications. All these are important. Anyway, when you see a mammogram, there could be, as Dr. Soumya was telling, that there could be microcalcification, which could be clustered microcalcification, branching might be there, spiculated margins. So all this, again, is an important factor. The words, so which the description of the lump is again an important factor before going to like, okay, it's BRADS 4, BRADS 3, whatever, but you have to go through the description. What all the features of the lump is present in the mammogram or ultrasonic mammogram report. So based on that, you have to decide whether the patient requires a core needle biopsy or not. Another thing which sometimes the examiners used to ask is that there are two views in mammogram, craniocranial and MLO view. So they sometimes ask why you just require a medial lateral view, why an MLO, medial lateral oblique view. So that is one of the questions. So this MLO view comes as this oblique view gives more information about the upper outer quadrant of the breast, which is a very important area for development of malignancy. So oblique view covers the, otherwise we might need another third more image. Mammogram, it's a painful procedure. So that one has, so we have to minimize the number of film. So the two craniocaudal and medial MLO view itself is very painful. So that is why medial lateral view is modified into MLO view, which actually gives more information towards the upper outer quadrant, so that quadrant is not missed. So that is thing. Then regarding breast cancer, I guess Dr. Soumya had already already gone through that. Then just one clarification regarding early breast cancer. So this T1, T2 with N0 or N1 is early breast cancer, and T3 with N0 is again early breast cancer. Okay, so that is the T1, T2 with N0 or N1, T3 with N0 is early breast cancer. Okay, so like we have changed a lot for like our concept has changed a lot from Halstedian concept to Fisher concept to spectrum theory and all. Earlier, we used to think that it is a local disease. You have to just radically remove the cancerous part and you might get the curage. But now we are moving towards the factor that it is actually a spectrum. It spreads locally as well as systemically, and we have to address both this part simultaneously. So that is a very important concept. So now treatment of breast cancer is always a multimodal approach. So tumor to breast ratio is a very important factor when you are telling about what mode of treatment you can offer to a patient with a breast cancer. So these are some of the additional points which I would like to highlight in this presentation, in addition to the topics which are dealt by Dr. Soumya.
Thank you, Dr. Jittu.
If any postgraduates have any queries, they can actually ask.
Yeah, chat box, Dr. Colonel Mohan Kubendra sir has asked for just to repeat the screening slide. Soumya, could you do that?
Just to summarize the screening modalities
Screening modalities.
and the periodicity of screening.
You can even read it out once more.
So this is the most common screening recommendation. So mammogram, they tell like annually for everybody 40 years and above age should undergo mammogram yearly. Clinical breast examination annually for a person aged more than 40 years and between 20 to 39 years of age, maybe 1 to 3 years, every 1 to 3 years. And breast self-awareness is recommended by the, so it's mammogram, yearly mammogram for more than 40 years of age, and clinical breast examination yearly for more than 40 years and 20 to 39 years, every 1 to 3 years.
Any further questions from the participants? I could not see any more. One more thing which I had come across in my practice, 1 or 2 patients who came for early breast lump screening, and they came, and I had sent them for mammogram, and I had not described how the mammogram is being done. And it was so painful for them, and they came back to me, doctor, you could have told me. So from that day, I had learned saying that once you send them for a screening mammogram, to explain the whole procedure so that they will not be perplexed during that investigation. So that is, as family physician, I think that is a highlight when we send for investigations. You could explain that procedure by whether it is FNAC, whether it is mammogram, or whatever, MRI or whatever. Even sometimes MRI, they can't tolerate the sound. All that things happen. So that will be another learning point when we send them for investigations. Any other questions in the chat box, Vishnu?
No, ma'am, I couldn't find any other questions. Mohan sir, if you want to make any comments, if you are available.
Good evening, everyone. Firstly, congratulations to Dr. Soumya for excellent presentation. It was very, very comprehensive, and she went through very methodically. Am I audible?
Yes, sir.
Yes, sir.
So, breast lump is a very commonly encountered condition in clinical practice, especially in the family medicine clinics. So it was very, very interesting and very relevant. I hope people who attended benefited by this. Thank you so much. So I basically wanted to know about the periodicity of mammography. So it is irrespective of the family history and all. So every female aged more than 40 years has to go through mammography annually, because I thought it is after 50 years annual.
Dr. Jitu, any suggestions?
Sir, actually, during our usual practice, we don't ask for a yearly mammogram. Actually, once after 40 years, we just do a screening mammogram, and then usually we follow up with a yearly ultrasound. Until unless patient has any significant diagnosis made out in the mammogram. So we don't routinely put them on a
mammogram. Because the recommendation says it is annual mammogram. That is what was
we don't follow clinic, because it's see, actually, once the patient undergo mammogram, if there is nothing, they won't be keen to undergo a mammogram again, at least in another 3 or 5 years of life. So that is one of the things. So, and another thing, sir, it is actually not recommended also, because nowadays the mammogram part which we do is ultrasound mammogram. So you have a ultrasound along with the mammogram, and you get a correlatory reports. So usually the radiologists themselves will tell you that what kind of follow-up is required. Mostly they will tell as a follow-up with ultrasound every 6 months to 1 year. If there is a like BRADS 3 or less than that. But BRADS 4, definitely we have to go for a biopsy. So, I don't think
what does this sonomammography imply? What does sonomammography? They do a sonography first and then go for mammography, or
we usually go for a mammogram first and followed by a sonogram. What happens is that, sir, there are many lumps which are like which may be detected in the sonography but may not be detected in the mammogram. Similarly, there might be any lump in the mammogram which may not be detected in the ultrasound. So that both has an importance. For example, sir, if a mammogram may not show a lump if the breast is very dense. Especially if a female around 43 or 44 years, as per the recommendation above 40, we go for a mammogram. But the thing is that her breast may be very dense, as like a 35-year-old breast. So her mammogram report may be negative or may not show any significant shadows. But the ultrasound might show a lobulated mass, which might require a biopsy. Similarly, on the other side, there could be a mammogram detected lesion, a speculated lesion or microcalcification might be there, but on an ultrasound, there might not be any lump visible. In that case, it poses a challenge to the clinician, how to go with that. Then what we do is we go for a hook wire based localization. That means based on the mammogram, where is the lump? So that particular area is localized with the hook wire, and that part is excised and sent for a biopsy. So both these possibilities are always there. So nowadays the recommended modality is ultrasonogrammetry.
Thank you.
There's one more question. How to differentiate between a lump from an engorged breast lobule on examination?
Soumya, actually, whose question was it? It was from
Dr. Himani.
Dr. Himani.
An engorged breast lobule as such, like a non-pathological single lobule being hypertrophied is a very rare entity per se. So usually lobule itself doesn't undergo an enlargement until unless it's a part of our ANDI. So that is one of the things. So I don't think so that there will be a clinical scenario where you have an enlarged breast lobule which has to be distinguished. So mostly it will be along with the finding of ANDI. So there will be a fibrocystic field, which we call a nodular breast, which is present bilaterally, rather than a single lobule being hypertrophied. A single lobule being hypertrophied mostly present as a fibroadenomas only, rather than being a breast lobule itself. It's a very rare entity. Until again, another possibility comes as a galactosyle in a lactating female. Only that areas only we get a single lobule as a mass.
Okay. One more question by Dr. Musliha. Indications for biopsy and FNAC.
So I guess any BRADS 3 and above, means BRADS up to 3 is fine. BRADS 4 and above requires a biopsy. So now our question comes is a core needle biopsy versus FNAC. For example, if it's a BRADS 3 lump, but there is a in the description it is hypoechoic breast lump of 3 centimeter, but there is no other features of malignancy. Only feature is either hypoechoic or some small lobulations. We are not suspecting a malignancy, but we want to be sure that it is nothing else. So at that case, you can go for an FNAC. But BRADS 4 and above, where you think there is a possibility of malignancy, it is always a core needle biopsy. For postgraduates, please do not use the word TrueCut. TrueCut is a company name. So the word you have to use is a core needle biopsy. Many examiners don't like. So it's a core needle biopsy. So core needle biopsy, what the advantage of core needle biopsy? It will give you a diagnosis. Along with that, you will get a hormonal status. IHC, you can perform IHC on that. So that is the indication. Another indication of FNAC comes is for axillary lymph nodes. So lymph nodes can, if you have a breast lump with an axillary lymph node, you can go for a core needle biopsy of the breast lump with the FNAC of the axillary lymph.
No further questions. Any more questions?
I don't find any more questions.
They can unmute and ask also. If it is not there, maybe we can wind up this.
Yeah, thank you, Dr. Soumya, for the wonderful session. As Ali Madam said, it was a full packed audience. We almost had 100 participants throughout the session. And thank you for taking so much efforts in a short span of time. And thank you all the attendees. And I would like to especially thank Ali Ma'am and Dr. Jittu, who have agreed to moderate the session. And I hope it was a very informative session for all the PGs who have joined. And thank you all. Hope to see you with some other session by next month. Thank you.
Thank you. Thank you. Good night.